Hello, welcome to our special live streaming series COVID-19 Frontline on CGTN. I'm Zhou Yun. COVID-19 Frontline is a special live show which offers a platform for medical experts from China around the world to share their thoughts and experiences on fighting and containing COVID-19. And apart from expert discussions, we also take questions from our followers on various social platforms, including CGTN app, the official website, CGTN official account on Facebook, YouTube, Twitter, and Sina Weibo. So feel free to leave your questions and comments on those platforms with the hashtag of my opinion on COVID-19. We look forward to your input. And today we have a special array of guests from the Hong Kong SAR and also several Latin American countries. And now it is my great honor to introduce to you all of them. Well, first of all, we have Dr. Liu Shaohuai, who's the president of Hong Kong College of Health Service Executives. So welcome to the show, Doctor. And also we have Dr. Christopher Xu Jianming, who's the consultant of respiratory and critical care medicine from Royal Free Hospital and the Royal Brompton and Harefield NHS Foundation Trust in London, and he was the consultant physician from the University of Hong Kong Shenzhen Hospital. And also we have two distinguished guests from Argentina as well as Brazil. They are, first of all, Dr. Omar Suet is the president of Argentinian Infectious Disease Society, and also the beautiful lady is Dr. Marta Cavalcanti, who's the infectious disease specialist from the Federal University of Rio de Janeiro. So thank you so much, everyone, for joining us. And without further ado, I'd just like to give the floor to the distinguished guest for today. How about we start from the lady first. So Dr. Cavalcanti, yes, if you have any question, please feel free to go ahead. You also need to turn on your audio because now you're still in mute. Thank you.
Do that? Oh, hello there. I'm so sorry. Hello, guys. I'm so thrilled to be among you today. And I was wondering if we could start with, something about what happens actually after, COVID-19, patients go out the hospital. We are having a lot of problems trying to rehabilitate those patients, especially the ones that go through, UTI and actually have lots of problems after that. In addition, I was wondering, since, many comorbidities like hypertension, metabolic diseases like diabetes, and obesity contributed, somehow to make, those individuals, having more severe, disease. And I was wondering, does that have any effect on the after, COVID-19, cure or, final symptoms? Do we have any more, probability to have those individuals progressing to, worsening their, previous conditions or something else? Do you guys have any idea about that?
Okay, so Dr. Liu and Dr. Xu, who can answer the question from the beautiful lady? Do you have any idea about the questions that she just mentioned? Who should we start from? Dr. Xu, yes.
Yes. Hi, thank you, Zhou Yun. And Marta, so in terms of my firsthand experience of dealing with COVID patients, both in China, in southern China, in Guangdong province, Shenzhen, Hong Kong, and in Europe as well in the second half of round two, I found that the rehabilitation, particularly of the more severe patients that you're talking about, to be a significant concern. You quite rightly point out that lung function on discharge is going to be weaker than when the patient was admitted to hospital. Often the deficit can run in the range of 20, 30, 40% of their original lung function, so perhaps even more. We've found many of our patients require oxygen on a long-term or ambulatory basis to support them, even when they go home. You quite rightly point out that hypertension, diabetes, and interestingly, right heart failure are significant problems. We found, particularly in Caucasian populations, that thromboembolic events, blood clots in the lungs, will cause a degree of right heart failure, particularly that requires monitoring and treatment. Aside from that, to my view, it's very important that these patients are put on a prescribed program of physiotherapy, regular occupational therapy, and speech and language therapy as well, because they may have been, for example, intubated on intensive care for a long period of time. We've seen patients, youngish patients in their 50s and 60s, who've been on ICUs for over 50 or 60 days at a time. And obviously this causes a great deal of deconditioning to the basic physiology. I'll hand back to Zhou Yun and Dr. Liu at this point to fill in on my answer. Thank you.
Okay, thank you so much, Dr. Xu. So yeah, let's go to Dr. Liu to see if he has anything to add on that. Yes, Dr. Liu, please.
Yes, I'm glad to follow on that subject because around the world there are many survivors of this pandemic. In fact, 70 years ago, when we had this SARS in Hong Kong, where we are hard hit, many of our survivors needs to be followed up for years. And in particular, you see that those with high risk factors, as you mentioned, heart, lung, diabetes, and also kidney diseases. In fact, they do have different complications. And at that time, because we have used high-dose steroids, so they added complication as well. Now, this COVID-19 is new to us, so we don't know what will be the outcome. And differently from the last pandemic, is that we have lower mortality. So in other words, in cities like Hong Kong and many parts of China, as well as in other parts of the world, where we have sophisticated healthcare infrastructures, in fact, we save a lot of people who probably would have died a decade ago. So in that sense, I mean, a more intensive program of follow-ups will need to be met out, not only by the national health authority, but also required a global collaborations of different specialties, like all of you here. So it's necessary that we share the information, and there would be some ethics difference. I would say that in Hong Kong, our number is not high, and our serious cases is not as many as other cities up to this moment. Although we are in Asian cities in Asia. And we plan to arrange some of the follow-ups with our traditional Chinese medicines clinics. So that has some evidence of or anecdotes reports that people would probably have lesser gas. So that is a Chinese term, okay, lesser gas. You found that you are not as breathing good as you were before. The traditional Chinese medicines would have kind of alleviating these kind of symptoms. And of course, they need to go into some kind of trials. So the public hospital system in Hong Kong, in fact, arranged at least in the beginning, 10 sessions of free attendance for these mostly whereabouts upon their discharge, in addition to their follow-ups at the respiratory medicine or their respective specialty clinics. So I think this is also a good way where a different country, you may have your other complementary medicines, supporting services that can offer the help. And in order that they can be rehabbed better and less admissions and have a more stable life afterwards. So that's all. I pass back to you, Yun.
Okay, thank you so much.
I would like to ask you this. That was a very nice, point, because you were saying that you were actually doing right now or planning to do on the follow up. Adding even traditional Chinese medicine or using drugs or products that are traditional, and maybe this may have a nice effect on the follow-up and the progression or no progression of those individuals. That's very nice. That's something, to go for, and actually, compare protocols from different, products, even the ones that we have here in the West. So maybe this is, how to go. That's great, believe me.
Oh, yeah, it is amazing. Thank you so much.
Dr. Liu, can I make a question?
Yes, please. Yes, Dr.
You
Soy.
commented about the pulmonary complication, but have you seen other long-term complications such as neurological diseases or immunological diseases in patients after several months of having COVID?
That's nice. That's nice.
So
I try to give some insight for you. The cases in Hong Kong are mostly mild, and so the long-term security requires a longer term of follow-up. And I can report here that currently Hong Kong is now moving into its third wave of outbreak, which is very much different from the first and the second. The first wave was around the end of January, February, the Chinese New Year seasons, where we see imported cases from mainland China. So at that time, the government has imposed border controls in order to keep down the outbreak. And the second wave, again, is more related to imported cases, particularly from the Western world, UK, US, Canada, some from Australia. So these people returning are mostly in the students and those working peoples. So they basically have better health. And our average length of stay will be around 15 days or so. So that is a average ranging from 10 to 20 in that sense. But now we are seeing that it is different. Now we have a really community spread within different districts of the cities. And mostly, as you have read about the epidemiologies in other parts of cities, other parts of the world, that those people with chronic diseases and also elderly peoples are more easily affected by this disease, and their medical condition really changes because the impact of the vasculitis due to the virus is not well known there. So these cases tends to stay longer, up to 3 weeks and even sometimes 1.5 months or so. And up to date, among the 3,000 confirmed cases, we have around 22 deaths. So this is reflect the Hong Kong situation. I will see that there will be complications not only in pulmonary but also those renal failure patients. They do have more intense complications as a result of their disrupted medical care. I don't know what is the observation from Dr. Hui in southern China as well.
Thank you, Dr. Liu. So in the course of looking after the more severe COVID-19 patients, what we found is, Omar raises a very good point actually, that there are occasional neurological deficits that are perhaps unexpected and not necessarily directly related to the virus itself. There has been this entity of viral related encephalopathy or encephalitis, with some question mark about whether or not the hyaline thrombosis, the microvascular infarcts we see more commonly in the European outbreaks, have really been a cause for microvascular injury to the brain. So effectively, small strokes, I think, is something that in the back of my mind I would be worried about in certain populations. But moreover, there's occasional groups of patients who seem to develop nerve damage. We've seen it with sort of 11th or 12th nerve palsies. And a lot of this seems to be related to prolonged intubation and intensive care management, which you would perhaps expect. But aside from that, as Dr. Liu has already alluded to, the chronic failure, the acute kidney injury, diabetic control, and heart failure are all things that we need to consider in managing these patients. I do think COVID patients do need to be followed up long term and regularly. We are starting data series and collection of these patients now as they are discharged from hospital to ensure that they have very good, very open access to the healthcare that they need. And I would urge outpatient services to be developed along those lines.
Mm-hmm.
Okay, thank you.
Okay, thank you both doctors. And also,
So, can I ask you guys,
yeah, of
have
course.
you been, seeing individuals that, manifested, symptoms initially COVID proven, then they got better and even cured, apparently cured, but again presented the same symptoms and again with COVID-19 laboratory proven. Have you seen individuals progressing like that, having two waves of viral detection and clinical manifestations? Have you seen that?
So Dr. Leo and Dr. Yes, Dr. Leo.
Yes, we didn't receive such reports of being discharged and then with a resurgence of the viral infections. Because in Hong Kong, we required several parameters for discharge patients from the isolation ward. First, they need to have two COVID PCR test negative 24 hours apart. And if the patient has a stool positive for COVID-19, then they also need to repeat the stool specimens twice before the discharge. And together with other parameters like the vital signs, the fever has been down for 48 hours, and all the biochemicals parameter returns to its normal baseline. So in that sense, people has been asking that when they discharge home and somehow they repeat the COVID, it becomes positive. But that needs to be reconfirmed with a viral culture of whether it is a valid, viable the virus or the remnant remains of fragments of a virus in some specimens. And in some of our research centers, namely in the academic unit under the university, they do measure the viral loads of the patients in the hospitals. And I don't have the direct report, but in fact, they observe that there is some fluctuations in the viral load. And that relates to the different kind of therapy they receive and the comorbidity, the health status of the patients. So I'm saying that COVID is really a challenging virus, a novel virus that we need to, investigate further, especially with more resources. All around the world, I think we are all already tightened up with the limited resources at the front line. And then you want to inject more research, data collections. They're really a big stuff. But I would say that, if we do have such questions in mind, you need to formulate a kind of study group where you collect the data at this stage, and then you further analysis. And as Dr. Hui and me has proposed that we need to have a more structured, long-term outpatient discharge, even up to several years, because there will be late sequelae of coronavirus in general. So
I believe that too. Yeah, that's nice.
Okay.
Yeah, but Dr. Liu, most of the reports that compare PCR with the culture shows that the virus cannot be viable after 8-9 days in mild patients or moderate disease patients.
Very true.
But sometimes in some very severe patients, there are some few reports suggesting that the virus can be recovered until 30 days. My question is, we are in Latin America now in the peak of the pandemic. We don't have many intensive care beds. And so many of my colleagues say this patient is admitted in the ICU for 35 days or 40 days. Why I cannot move this patient to an area without COVID isolation? What do you see is the safe timing for releasing the isolation inpatient in respiratory assistance in intensive care?
Perhaps if I answer that
describe
question.
the Hong Kong situations, and then Christopher may add on his experience. I mean, we do have variabilities among the patients and people on the two extremes, or patient on the two extremes observed. So it is definitely that for the national societies or the national health systems to decide a agreeable criteria for discharge and also admissions. Okay, so that is very important because it related not only with scientific findings, but also the practicality of the resources that you can mobilize. In Hong Kong, all the isolations remains within the public hospital system. So we have only one system, that is the hospital authority. And she takes care of all the isolation facility in the cities. So if you are being treated by private physicians, they need to refer in into the system. So in fact, they have a full database of all the positive cases. And with this experience, they're making sure that people discharged, either they could be care at a suitable facility, or they themselves have the ability of care themselves, of self-care. So that is very important. So once you discharge home, the hygiene advice given by nurses are strictly implemented. So the patient are advised to keep, still put on a mask for 2 more weeks, and then observe their symptoms, self-check their body temperatures, and they were provided with a hotline where they can inquire with our medical teams to get some consultations on whether they need to return to the outpatients for a check-up as soon as possible. And that really related to different chronic diseases, because in Hong Kong, those hospitalized, those patients that are being followed up at the hospitals with the different chronic diseases, they have set up a contingency plan for their own group. Oh, so now let's move on to another topic that you asked. So people that could probably be more fragile, they treated in the ICU, and hopefully it reached the criteria of discharging from the ICU to a general ward. And what is the caring? Okay, so in Hong Kong, we designed the so-called step-down ward. Step-down ward. So that is a situation where we still keep the isolations environment with good hygiene and infection control practice, but then the nursing care could be lesser than as in the acute hospital. Now, this type of concept where the patient are being cared at 2 levels was much more experienced in mainland, where they have the Frontline, the so-called mobile cabin hospitals. It is a temporary hospital set up that can accommodate a greater number of people before they're being discharged back to home or to their community. So this is a good experience, in particular in South America, where you probably have some vaster places and factory that may be able to be temporarily rental to the government for set up such kind of facility, or even exhibition hall. In Hong Kong, we are a very crowded city. We don't have an open space as much as you have, but then we have a huge exhibition hall, which is now laden opened because all the activities have been curtailed. It has been stopped because of this COVID. So they are willing to be lent out for such kind of a step-down care. Okay, of course, from time to time, there will be one or more that becomes more seriously ill, deteriorated, and then you need to refer back to the acute hospital, as I mentioned earlier. But you see, in Hong Kong, we are really very crowded, and even our nursing home, that is the elderly home, they are probably not best suited for people who cannot care themselves, require assisted care, personal care, to be managed at a very crowded condition like Hong Kong. So that is another experience where cities where you have probably have a more crowded areas, the basic social classes will focus that you probably need to plan off about the discharge strategy. Because once if you discharge them and then they cannot manage well, there will be a return. The backfire become a surge. You know, nowadays, the surge is the most difficult, the most challenging problem for all the health planners. So if you surge, you in fact make the whole healthcare systems cannot operate in a normal way because of the large number of people in your A&E department, a lot of people waiting for admission to ICU, and your ICU team people are overworked and they are tired, and some of them may get infected and need to be, out of work. So that is really a problem. So again, to you, Dr. Hui.
Thank you, Dr. Liu. As you alluded to, I think this is the case. We're really dealing with different pressures in the context of different health services. In southern China, in Shenzhen, we were fortunate in that we could retest patients before discharge. So we typically required, on the standard basis, 2 negative PCRs prior to discharge from isolation. And at our hospitals, actually, I increased the requirement to 3 negative PCRs over 72 hours. Again, this won't be possible in every service, but coming back to Marta's original question about adaptive immunity, it is possible to have serially negative samples and then for it to come back positive later on. I think I recall one particular patient where we did 7 PCRs serially for COVID, and they were negative, 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 positive, negative, negative, positive. And I think sometimes these, again, to do with the sensitivity and setup specificity of the test, there can be some technical issues sometimes, but all I can say is in that situation, you have the opportunity to retest, to revalidate what you're doing. In terms of the virus shedding itself, it is variable. The part of the problem is, of course, we know that the asymptomatic transmission of COVID happens in the early days when the patient isn't exhibiting particular symptoms, but is perhaps generating viral loads that are then being communicated in public spaces and on contact surfaces and droplet spread. So really, to our mind, the best way to break the chain of transmission and to adhere to the sort of principles of infectious diseases control by identifying and isolating, confirmed positive cases, we really do have to scale up testing. And antibodies are difficult because adaptive immunity is not necessarily sustained. And this is the whole question about vaccines and whether or not over time they will provide long-term or sustainable protection to the individual. I have no doubt, I think Dr. Suet mentioned previously that there have been vaccine studies done. There's a very good one in The Lancet last week by a company called CanSino, which have looked at the sort of antibodies that can be generated with a modern vaccine. And it seems to work reasonably well on the basis of the data that's been published. The issue is, can this be sustained over time? Thank you.
Okay.
Talking about, talking about this, I love it, when you said about, how testing has become, a difficult issue because immunity is largely different from what we expected. As I'm talking about, detection of IgM and IgG levels can be variable and very short duration. in large numbers of people. So for, screening a whole population and maintaining, surveillance, those tests, seem to be kind of unreliable, or our immunity is kind of, very different from what we expected. So I was wondering, do you guys think, that we should improve, the tests, and also we should, address with other, actually, different choices for detecting individuals that are actually with, an actual disease, or the ones that had one, and we have to make, decisions about, do you isolate them, do you not isolate them, starting to thinking that people actually are coming back from the isolation. Here in Brazil, they made it that flexible, and people are coming back to their business, and now we are going to open schools. How we're going to be sure that we can detect, really detect individuals that, do have, infection, having symptoms is great because we can detect them very early. But if they don't have any symptoms, how can we actually, believe on unreliable tests like, serology or IgM and IgG detection?
Perhaps if I jump in there and answer that, from what I've seen in different countries, from moving between China and Europe, testing, the mainstay of testing remains RT-PCR. We have to rely on the sensitivity that this gives us. Antibody testing is problematic, I agree. It is difficult, but it is improving. We've come a long way since January and February. I think the ELISA kits that are commercially available now are better than they were in the early days. I think part of the problem was there was a great rush in February and March to develop these test kits. And the problem was that they were being drawn on very limited numbers of patients. In some cases, I've seen kits developed on the back of 23 samples, 23 individual patients.
Very true.
And the problem with that is that these samples were often the most easily available in the hospital. So they were drawn from patients on intensive care. In other words, they weren't originally drawn from patients who are representative of actually what's going on in the community. And so with that kind of skew, the advertised sensitivity of these kits was lower than the 55 to 70% range that they were advertising. Again, through no fault of the marketing, I think it's just difficult. These things in the early days are unpredictable in terms of their sensitivity and specificity.
That's true.
But as time has gone on, these tests are definitely improving. I have been tested myself multiple times, and I'm pleased to say that my IgM and IgG are negative still, despite having been working in various frontline capacities for over 6 months now. And in the course of my work, I've had repeat multiple, well, 15 to 16 repeat PCRs as well. And this is necessary because staff have to be tested to prevent transmission to patients and vice versa. So we really do have to have a very clear understanding of how we divide our workflow into those who are red and green, or the hospital into hot zones, where patients who are positive are protected and isolated from those who are not. This is, to my mind, the only way we're going to break the chain of transmission over time.
I agree, definitely.
Yeah.
Maybe also I can add to that.
Right.
In mainland, they have experienced that kind of so-called healthy cold. So it's a kind of apps. I'm not very sure about that. I'm just also reading from the newspaper where they have kind of apps or some kind of coding where you given the green lights, that means you are healthy, you probably checked with the PCR, or you are being discharged well, and then you can go back to your community, you can return to your workforce, your workplace, and you can travel across the provinces like that. Hong Kong hasn't adopted that. First of all, because geographical, we are very small. So in fact, we are a very small locality, and then easily can travel within an hour or so, either by public transport or by bus. Okay? And we are densely, we have 7 million. So we have a highly densely of the high rises also. So the most effective way of identifying who are the potential carrier, who are the potential spreaders, is the infectious disease golden rule of the FTOCC. Do you remember that?
Okay.
Fever, travel, occupation, cluster, and also contacts. Okay, so that was well during the later part of the SARS in 2003, and also in practice for the flu pandemic the swine pandemic in 2009. Okay, so that is really being familiar by the citizen, by the public at large, and also of all the frontline health workers. But currently, you can see that there are reports of where there are inconspicuous patients who probably has a larger viral load at the beginning of the few days, or even 1 or 2 days during the incubation periods. Okay, the science need to establish that, but we cannot wait for science reports, because these people can spread so-called the super spreaders, as reported in Heilongjiang, the northeast China, where a returnee from the United States who diligently followed the advice of the home confinement for 14 days. She did not travel out, she did not have fever, but then during her return to his own flat by taking a lift, he probably contaminated the environment, and whereas another resident living downstairs, 1 floor downstairs, contracted it and then passed to her boyfriend and then to family member. And that was, that was described elsewhere, reported as a super spread of 1 spreading affecting 71. Of course, such kind of findings requires very draconian follow-up investigation, takes months to establish. So the best way, if you do have the resources and you do have a confined geographical regions, then you cordon them off and do the PCR test. I agree with Dr. Christopher Hui that at present moment, the PCR has the sensitivity and also specificity compared to the blood test. Yes.
Well, it's a good point. You just, said that if you have the resources, actually, if you can use, RT-PCR or RNA detection assays, that would be better as, to manage, transmission in a population. But when you're talking about, low-income countries, especially in Latin America, we kind of have, a little problem with that. Always we have, RNA detection assays. They are very expensive, and even serology here, since they are, imported, we are having a little problem with, our budgets, to support, that expense. How would you imagine, to do less expensive, surveillance in a population, when you have those problems about, short money?
That's really a dilemma, okay?
Yeah.
On one hand, you want to have the protection of the populations. On the other hand, you need to convince your Ministry of Health, okay? So I think there could be some point you can take away home tonight. Also, you can tell him that if we do not confine the outbreak, the community outbreak at the early stage, and probably the hospital costs will cost much, much more than the PCR tests. And the PCR tests, and really, I think there are international aid, and the tests has been manufactured by so many factories. The cost price is coming down. In Hong Kong, although I mentioned that we are a so-called densely population, we do not adopt like China, where they can do a pan-population screen. We do a subgroup, sub-target group to screen it. Currently, we are in the third wave. So with the initial epidemiology finding, we found that there are 4 subgroups that we can focus, and of course, save money a lot. So the 4 groups are, first of all, are the elderly home and the institution for the disabled. Okay, both the inmates, the residents, and also the employees. So that is just a handful of numbers. You can have around 1,000 institutions, but each institution will be about small numbers up to 100. Hong Kong is very small space. Okay. The second group is the taxi driver. So with the epidemiological tracings, they probably found that many of those clusters reported taking the taxis from some routes, some part of it. So taxi driver, in fact, becomes a so-called a mobile spreader. And despite their diligence in that, we immediately screen that because they may be infected and they become the latent carriers, which is going to transmit the virus to another group. The third area is the wet market. I don't know about South America, but Southern Chinese used to go to wet market. That is where we have the COVID cat and the SARS virus in 2003. But now the wet market is much more improved, but still the practice of a wet market where people mingling around and they feel that they are very safe. That is the culture. So all the tenants of the wet market as well as the employee will undergo the checking. And that PCR checks really give confidence to the public. You see, if there are some positive cases from the fish market, from the chicken markets, then people become panic because they used to buy the chicken and fishes once a week or twice a week. So the whole city will become panicked. And then, and the health authority need to address this not just public health issue, but also psychological issues of the population. Okay, the fourth group is the Hong Kong is a very dynamic city. We have a lot of vigority. If you visit Hong Kong, you know we are the 24-hour cities. People love to eat. Okay.
Wow, seriously?
Oriental cuisine and also South American cuisine, also European cuisine. So and it's really cheap. So that's why people listen. Now we are not going to have a lockdown of the city. The lockdown of the city will really affect the whole operation. Particularly Hong Kong is an international city. So we focus on the food and catering handler. Food and catering. Just now when we handle an outbreak of food poisoning, food poisoning during the summer times, cholera, then we do a subgroup checkings and also give good educations, just-in-time education about how to handle. So hopefully with these initial injections of a bit resources that you can convince your Ministry of Health or your public health authority that when you cordon off, you making sure that the initial spread within a certain countdown, then you know what is the workload to follow. So that is the dynamic. Okay, where you wish to put more resources in your ICU, in elderly people being admitted through A&E and then stay for 3 weeks in ICU, that really costs a lot of money. It not only costs a lot of money, it also costs the effort from the medical and nursing team. Whereas in our screenings, we employed auxiliary staff. People can easily train because the technique is simple techniques, and the time taken for a specimen collections is easy. You can at a playground. And in Hong Kong, the University of Hong Kong has defined that deep flow saliva that you collect in the early morning. So you can collect early morning, send to the laboratory, and it is very fresh, and then you can have the result maybe within the same day or next day. So you can really know the positive case as early as possible. So these are some of our experience sharing to you.
Yeah, that was
Yeah.
very wise. I love it.
Thank you.
And I was thinking maybe, Ministry of Health is going to start here to test everybody on the beach and having, barbecue parties, which actually are very, very,
Yeah.
popular around here. That was very nice tip.
I can
Nice
share
tips.
I can share statistics with you. The statistic was announced by the Public Health Authority on the 27th. That is 2 days ago. So for the past three weeks, probably we have distributed out these screening bottles, collection specimens for what I mentioned about the. So we have 3,700. So not a large number, 3,700, and we
Wow.
can identify 8 cases. 8 cases. So that comes to 0.2%.
Uh-huh.
0.2%. Okay. So this is, I mean, on one side, you are assured of course, you cannot do simple affirmative by just multiply it by 10. We don't know because the process of screening, target group screening is ongoing. So on one side, you probably assured that it's 0.2, not too high. But on the other hand, you will be assured that the effort you spend out, you probably stopped 8 person, particularly from this group, who will be moving around the city and become
That's very true.
become
That's
the
very
source
true.
of
The
Yes.
spreading. Yeah.
so you can, yeah. So you can also have your own pilot study in one of your region or district of your cities and to see. But I'm not sure. May I also ask the questions to Omar and also Maria that you do have a rural area, countryside, so farmers and that. What is the situation over there on those small townships? What is the situation?
Okay, on my side, at least we are seeing a movement, from the big cities to the rural areas right now. So the number of cases, in Brazil, this is a heterogeneous country. You have regions that, are a lot different from each other. But this movement from the big cities to rural areas are happening simultaneously in almost the whole territory. And what we are actually seeing is that in the big cities just got high numbers of cases. Still we are not going down, but didn't stop the spread to rural areas that are becoming now which numbers that are increasing and very in this like gradient like 10%, they are going up very fast, and that's how things are going on right now.
Okay.
On the other side, Ministry of Health decided, to advise, the local areas, to make options in terms of, doing more isolation or less isolation, depending on the number of beds that are occupied at the hospitals. So that is the main, issue, because they use the hospitalized individuals to measure how infection is going on in the area. We are not having testing for everybody, so testing is for small groups. For instance, healthcare workers are the ones that are systematically
Right.
being tested, but we are not doing testing for the whole population or larger groups that are
Right.
representative of spreaders in the population.
Okay.
That's one problem. So we don't have reliable measurement of what's going on. So people get thinking that in Rio de Janeiro, for instance, we have solved the problem, and that's not true. Infection is again going around, and people just get infected by chance, and it's higher depending what are you doing. The masks and washing hands, are things that are basic.
Yeah,
But
Dr.
you know, they are
Dr.
not doing
Cavalcanti,
that
I'm sorry, I
now.
have to stop here because, yeah, let's turn to Dr. Suet to see if he has any observation or something that he'd like to share. And then we can go to the followers' questions because now we are receiving a large amount of comments and questions online. And then hopefully we can give them a chance, one or two, to address their questions. So, yes, before we go to the followers' questions, Dr. Suet, do you have more to share, please?
Okay, yes, Argentina had a very different pattern of response to the COVID than Brazil and other Latin American countries. The government established a lockdown very early in the epidemic. With only 100 cases, we started a big lockdown. This was good because protected all the rural areas, but unfortunately, in May, the infection started to rise in the capital city, that is very complex, and entered in a very vulnerable neighbor. That increased the cases in all the Ciudad de Buenos Aires and the metropolitan area. And now the epidemic is out of control. We have 6,000 cases every day and 100 deaths every day. The system is overflow with patients, and we have 65% of the intensive care bed occupied. So the government, here is the problem between going forward, making more tests for asymptomatic people, or focusing only in the symptomatic cases and the contact of the symptomatic cases, because the system cannot afford for do testing for everybody. And then the problem is that when you test, if you don't isolate this patient, it's for nothing. It's waste money. So we don't have places where to isolate those patients. So some hospitals are releasing mild cases to home to continue the follow-up of the treatment. And that is ridiculous, because you are sending back to the community, to people that can continue infecting, even though they promise that they will not be in contact with other familiars. So we are waiting for increasing the capability of the system to isolate people, and we working with CanSino and other vaccine programs in order to try to be involved in this research in order to have access to the vaccine early in the program. But the problem we are seeing now is the big city is having the 90% of the cases in the country. But this also is affecting the rest of the rural area, because the trackers are going to different provinces and starting outbreaks in each one of these provinces. So the chaos is starting to begin in Argentina, and we are very worried about the need to lock down again when the people is tired of the lockdown and the society is divided between the official recommendation to don't move and the opposition that is using this in a political way.
Okay, thank you so much, doctors. And just as said, now it's time for us to take a look at the questions and also the comments left by our followers on various social platforms. And actually, my colleague has picked up a few. Let's see, because I think we are a little bit running out of time. Let's just see one of them. It's from Facebook. And the question is, the first and frontline symptom of COVID-19 is usually high temperature, if not mistaken, of which temperature temporarily fluctuates due to a number of short-term factors, including stress, type of food consumed, etc. So, is high temperature the only measure? Yeah, I think this might be also a question that is, concerned by many of the followers who are now paying close attention to our live streaming and also the COVID-19 pandemic. So, Dr. Hui or Dr. Liu, who can answer this question to our followers? Dr. Hui.
Thank you, Yun. Fever is definitely a defining characteristic of the onset of the viral illness. However, aside from that, they may be accompanied by a cough, breathlessness, and other symptoms as well. In up to something like 25% of cases, there's also a degree of diarrhea, which may speak to other parts of the body, including the bowels, that may be affected as well. the constellation of symptoms in a viral illness is difficult to track because the onset of the symptoms can be varied over time. As we've said already, sometimes the patient can run for, someone who's infected can run for quite a number of days, up to a week or more, without showing any symptoms. And so by the time they show symptoms, the viral load, as it were, the number of viral particles that have replicated within the body is already at a level where it's achieved a sustained infection. Whether it then goes on to become a mild, a moderate, or a severe illness really depends on the nature of the individual, whether they have any other health problems, or whether or not there's underlying sort of risk factors in their innate or adaptive immunity. There do seem to be some people who are more vulnerable, not only to COVID, but also to more severe forms of the infection, as we've seen with sort of other health risk factors becoming a concern. So I think that fever is certainly something to look out for. If people out there are developing a fever, they should certainly check their temperatures. You'll notice in many parts of the world now, many hospitals and major public areas will use thermal imaging and FLIR, so infrared thermal imaging and gantries, to read temperatures as people walk past. This is similar to what can be done at train stations and airports. It isn't perfect. It's not 100% sensitive. It doesn't pick up everybody with a fever, but it's good enough, and it's better than nothing. So even if you were, I always argue, if you pick up 30 or 40% of the people walking past with a fever, then you're achieving something in terms of screening. Just to come back to one of your points earlier on, I do very much appreciate that logistics and costs are a very big issue for many parts of the world, and it is a very heterogeneous problem. Our president has said previously that China is in fact a moderately prosperous country, and that we are aiming for a modicum of prosperity as well, like yourselves. And I think the way to recover or to spare our resources, for example, in testing, is by scaling up the testing to reduce the cost per test. And then, as Dr. Liu has said, to target those tests to where you think the most benefit will, or the most likely yield will be, where you're most likely to pick up people who are positive. And I think with that, organizations like the WHO are very useful in helping us all guide our practice and target our resources in the most cost-effective and most sort of efficient way. Thank you.
Okay, thank you so much, Dr. Hui. Yes, Dr. Cavalcanti, because of the time limit, this might be your final question. So, yes, and you need to unmute yourself, sorry, because you need to turn on your audio. Sorry for that.
Okay. Oh, I just want to thank, Dr. Shao and Dr. Christopher, because you guys, actually brought up, good, information and tips about everything. I like it in your last observation, Dr. Christopher, about, reinforcing Dr. Shao, saying that we have to put our, efforts and even money on, strategies that are, can be, more effective. And I just wanted to add about, the fever, because some cases actually do have presentations that are a little bit atypical, and they can happen. So fever is not 100%, marker of disease. So we have to pay attention on that, and that might help to detect other cases that are a little bit different from, the regular ones. And thank you guys for all, the answers. That was very good.
Okay, thank you so much, Doctor. So how about Dr. Suet? Before we wrap up, do you have more questions to ask?
Thank you very much for your contribution. My question is how you are preparing for the new outbreaks in your countries, because most of the population doesn't have immunity, and so this means that the introduction of cases from other countries can be easily followed by outbreaks in your country?
That's a nice question.
Yes, so Dr. Liu or Dr. Hui, who can address on this very final question?
Well, we are world, okay? Globalizations, in fact, has created city like Hong Kong, London, Sydney, whatever part of the world. So one way to tackle this problem is that we probably need to reverse our globalization. We probably put some temporary border control, travel restrictions in order to slow down the movement of people. But at the same time, you are facing a dilemma because a lot of goods, a lot of financial and also commercial activities need people. So here's where the IT and also the technology comes to help. So humans are clever beings. We probably think of a way to solve it. So then we zoom down the problem, same. So for a country like Brazil, Chile, in South America, you probably need to have some control where we are now talking about social distancing in the city. You can use another term, social isolations. That is, we try to isolate a group of people in different. While I agree that fever is not 100% presentations of COVID, but fever is the most objective, most simple one, and it will count at least at some part of the disease causes. So we can train up our people, the populations, that they need to have a self-awareness and also they self-manage about their body temperatures. So that is easily done in city because cities are people are much more willing to access to such kind of infrared and also the thermal the temperature to be recorded. So I used to ask my friends in the society that we check the temperature morning and afternoon. Okay, so once you see there is probably a trend of going up, then it is probably a early warning sign. Now, talking about technology, there are technology where you can, like the wearables put on your arm, where they monitor a very subtle changes of your temperatures, okay? And they have some kind of AI at the end with the algorithms. And for those people, as mentioned earlier, with chronic diseases, comorbidities, that could probably a way that we can, besides going to see a doctor, doing all those PCR tests, expensive, we can have early sign, and then we move them to a isolation camp, some kind of confinement, and at least we stop the spread. I think nowadays the first thing is we stop the spread so that you don't have several hundreds of confirmed cases each day. I mean, that is really very, very worrying and also very tiring.
Okay.
Thank you very much.
Thank you so much, Dr. Liu. Dr. Hui, do you have anything to add?
I think just in summary, given what we've discussed so far, we really need to have a new set of strategies going forward for best treatment, the best approach for efficient screening of large populations. The problem has progressed a long way since we were looking at a few tens of thousands of patients in early February and March. I think at the last count with 16.5 million COVID positive individuals internationally, globally, we are now looking at what is become the largest pandemic of our generation. And I think it takes a great deal of discipline. It takes a lot of cooperation, working together, efficient communication, like today, to share our ideas and concepts. Obviously, we all face different problems, different contexts, different environments, where with resource limitations, we are not always able to do the same thing. But I feel that, in what we've learned, there are ways around very complicated problems sometimes, such as testing and the standardization of treatment for COVID-19. In all of this, I've been heartened to see, very dedicated, very hardworking and very brave individuals all around me. You know, I have nothing but the greatest respect for all my colleagues and the nursing staff who've really spent a great deal of not just their time and professional efforts in looking after others, but placing themselves and their own families at risk in order to do so as well. And I think, you know, there's a great deal of achievement in that. So thank you very much for allowing me to participate today.
Okay, thank you so much, everyone. With that, we're going to wrap up today's discussion. Just as our doctors, Dr. Hui, Dr. Liu, and other doctors from Latin America, international cooperation, trust, and solidarity are one of the most key factors to help us fighting this pandemic. And I think that's also what made today's discussion very, very impactful and also meaningful. And hopefully the information that was exchanged today, the consensus reached, can help not only us, but also many other medical doctors and experts who are fighting at the front line to better cope with the challenges, in this pandemic of COVID-19. So thank you again to our, doctors for your time and also your experiences, and also a big thank you to our followers for your submission. We'll have more to come next week, and thank you. Bye for now.